Thank you very much. And good afternoon, friends. And indeed, we had a terrific talk just before me. Dr. Mahipal and Dr. Sirignes talked about innovations. And that innovative lens can be only put if you do a good surgery in a difficult situation also. And one of those is a posterior polar cataract, where things can be very difficult. We all know that chances of a posterior capsular dehiscence during every step of phacoemulsification is there, and it can range from 0% to 34%. And with experience, that will decrease. But experience will be basically how to examine your patients clinically before doing surgeries. So it's important to look for what are the risks in those cases. What are various things we look for? We look for how big is a posterior polar disc. Larger the disc, more chances of a rupture happening in these cases. Harder the nucleus, more chances of posterior capsular rupture. So these things has to be assessed very nicely with a real-time examination. And if you have this type of appearance, this indicates that you have an open posterior capsule in this posterior polar cataract. So risk-wise, you have to assess your patient. Accordingly, you have to image these cases and harder the nucleus, as said. So there are two ways to look into your patients, which can give you an actual three-dimensional picture of a cataract morphology. So you can do anti-segment OCT before surgery, and you can do an intra-op OCT if you have a microscope which has attachment to intra-op OCT, or if you are using a femtosecond laser, as Dr. Mahipal nicely showed, you can have OCT in those cases also and see how it looks like. This is one example of anti-segment OCT imaging of posterior polar cataract. So this is the entire disc, the depth of a posterior polar, and this is the size of a disc of posterior polar cataract. What we are looking for is the clearance between the posterior polar disc and the posterior capsule, and the clarity of visualization of posterior polar cataract throughout the area of disc area. So according to that, we have classified these cases as difficult scenarios. And this is one publication from our center done by one of my younger colleague, Dr. Amar Pujari, where we looked into a consecutive 100 cases of posterior polar cataract and done the anti-segment OCT imaging of these cases. And we found that there were three important morphology under anti-segment OCT: conical shape, moth-eaten appearance, and the eclectic shape in these cases. If you have these shapes, these three important shapes, you have a very high chance of posterior capsular opening during your procedure. But if you have routine morphology, then there is a very less chance of posterior capsular opening of these cases. So this is a very important way of looking for any cataract, more so for posterior polar cataract also. But intraoperatively, you can know the dynamics of each step by a OCT in the microscope as such. And we had a similar pictures being picked up in our OCT microscope also, and we have classified them type 1, type 2, type 3, based on the visibility of a posterior polar area. Like this was a type 3 moth-eaten appearance, where you cannot see the posterior capsule at all. So this patient will have a very high risk of a posterior capsule opening, and the disc is also thicker and more denser in these cases also. Therefore, it is important to do a nucleotomy, because that is the most challenging part in a posterior polar cataract, in a safe manner. And this is a technique we have recently described, and it's available in our IGO now, a phaco chop technique, where we do a chop and tumble technique. In that, we do a delineation only, and no rotation is done in these cases. Make sure you have enough cushion of a posterior epinucleus plate. You can see here, this is the endonucleus. This is the epicortical cushion after hydrodelineation. And no hydrodissection should be done in a posterior polar cataract of variety type 2, type 3, or type 4 in such cases. So this is a technique of emulsification. What we do, we make a little trench in the center. We have tried to do a delineation in this case, grade 3 nucleus. Do a central chop and take out the one pi of piece from this side, right hand side. The one piece has been taken out. This will give a space for a fluid to complete the internal hydrodelineation, and that will loosen the nucleus in such case. Now this can be tumbled in without rotation. The entire nucleus has tumbled in. Now I can chop it subsequently. Same for this also. I can just pull this towards the central area and complete the nucleus here. So this is the entire nucleus emulsification without rotation. Once you don't do a rotation, it doesn't disrupt the epicortical cushion. That safeguards the posterior capsule till the end of these cases also. So this is the same technique been shown, and in IOCT we'll see how much fluid had gone inside the epicortical cushion and endonucleus to separate. This is the nucleus here. This is the multiple delineations happened in such cases also. So you can do a procedure very, very effectively. So this was the type 4 variety of case where posterior capsule is open. In such cases, this is a type 3 case, moth-eaten appearance you will see in the OCT pixelization, onion peel appearance of around 4 millimeter disc of posterior polar cataract. In such cases, you have to really moderate your phaco parameter. This is the moth-eaten appearance. Do around 4.5 to 5 millimeter rhexis. Do the hydrodelineation here. During this hydrodelineation, the posterior capsule opened up. In posterior polar cataract, you can have a difficulty or you can damage the posterior capsule integrity any stage. More so in a hydrodelineation dissection here. So you can't rotate the nucleus here. I'm doing the same technique of chop and tumble. Give a space for a fluid to sheep into in between the endonucleus and epicortical cushion. Subsequently, you can tumble the pieces with your second instrument without rotation of epicortical cushion. And take out the epicortex towards the end. We know that capsule is open in this particular case here. So never let your chamber collapse. I'm trying to take out my cortex as far as possible. Then I'll take out second instrument and replace that with a cannula with a dispersive viscoelastic to tamponade the opening of a posterior capsule and tamponade the anterior vitreous face. This will also give you access for doing a bimanual aspiration of a remaining cortex and inject the IOL safely here. Never do a wound assisted insertion. When you have an open capsule, do a inside and then tuck the haptics underneath the capsule margin. It will go inside the bag. Don't try to rotate vigorously in these cases. Fix the lens. Subsequently, you can still complete in the bag implantation in this scenario of open capsule also. So this all depends on how better you have done the pre-op investigation, OCT pixelization, then manipulating your surgical technique and moderating your phaco power, energy, the flow rate, and maintaining the antechamber integrity throughout. Now, this is a publication, the technique we published long time back with a femtosecond laser. Here also we have done 3 rings of safety and 8 chops. That gives blocks of a nucleus pieces here. And this is the OCT pixelization which tells you that there is a posterior polar cataract in these cases also. So surgery becomes very safe here. So we have a chop here, we have a blocks here because we had done a 1, 2, 3 rings here. You'll see here each area, once you split the area, the bubbles will come out. And that will decrease. No hydro procedure has been done in this case. So this is a primary block I'm taking out one by one, no rotation being done. And this is a secondary block of nucleus being taken out. So this is called block by block disassembly of nucleus pieces. Classically, for manual surgery, we have described this as a layer by layer phacomulsification in a posterior polar cataract. So this is how effectively you can take out the nucleus safely in these cases also. To summarize, how to make your surgery safer for difficult scenarios? One is good examination, good delineation morphology of your cataract. More so a posterior polar, type of posterior polar pixelization is important. Avoid hydrodissection, do a delineation. If delineation is not complete, you can do a complete delineation by a chopping, allow fluid to seep through and it completes the delineation, and do a tumbling type of technique without rotation. Nucleus can be pulled to the center and emulsify better. If you have access to femtosecond laser, nothing better than that in posterior polar cataract, but that gives a pre-rhexis, pre-chop, pre-delineation of the phaco, and surgery become very simple in these cases also. As I said, I require your support from the entire belt of Andhra and Telangana and Odisha. Thank you for being such a nice support for me, and hope that I'll be again in this place, beautiful place of Vizag. I think this is my second trip. I'd like to come for many, many times. Thank you again.
Thank you, sir. Thank you. It was such a beautiful demonstration of, I think, one of the most important challenging cases that all of our delegates, I'm sure, they must be experiencing. When it comes to the use of femtosecond laser technology, so, sir, have you done any study between like manual versus femtosecond laser for posterior polar cataracts?
Yeah, this particular pattern we, I think, published 6-7 years back, and in that also we compared the manual subsequent 100 cases. From the femtosecond, there were 40 cases of them, and in both ways we didn't have the significant difference in terms of a complication. That's mainly because it was experienced surgeon doing surgery in these cases. And we understand how to manage these cases also. And if you see the 100 cases we have done of anterior-segment OCT, we have looked into their surgeries and the risk factor. There also, except for those three typical features like conical shape, ectatic shape, there we had a more chance of rupture. Out of 100 cases, we had around, I think, 4 cases where capsule opened up. Otherwise, it was almost similar in both the groups. But yes, surgery-wise, femtosecond gives a little safety more. You can cushion your, manage your, customize your epicortical cushion there. You can do a pre-chop. So that's a little safety. If you have access to this system, do it with the femtosecond laser.
Thank you so much, sir. If there are any other questions from Dr. Bharti, sir, or from any of the delegates?
Of course, we understand that posterior polar cataract is a very difficult situation. But majority of times we understand that unless you have done a OCT beforehand, it's really a diagnosis which is more scary. And I would say that more than 50% of such cases are only posterior subcapsular and not posterior polar. So one has to be very clear and diagnose with the OCT that this is really posterior polar, and then take sufficient precautions. And then if you have option of doing it with the femto, then I think the femto is the best option. Yes. Use the mic, sir.
What AIOCMTC2 was used, because the regular OCT, even if we use the anterior attachment, doesn't go to the posterior capsule.
No, it's a regular anterior segment OCT because that has a better, resolution, and we use both, this. What is the name? I don't.
Cassia and IOCT.
The IOCT is the microscope.
Yeah.
That's with the Zeiss microscope.
Yeah.
It has a slightly lesser resolution than the actual anterior segment OCT we use. This is 5 micron resolution.
So regular retina OCT with the anterior segment attachment.
Even that can give you a very nice access. We use that also.
Is it Vizante, sir?
Vizante and Heidelberg also. Yeah, it's
Heidelberg
OCT in the microscope.
Next is.
Can I?
Okay.
No, I think as far as the OCT picture is concerned, there's a very high negative correlation. Am I right in the sense that if you have all those apparent disruptions in the posterior capsule, you may or may not have an event during surgery. But if the posterior capsule appears absolutely pristine and there's no irregularity, that means the case is likely to go off. As a clinical application, I have been wondering whether, obviously when we do just a hydrodelineation, no hydrodissection, the surgery definitely becomes a little more difficult, takes a little longer. So when you don't have any disruption of the posterior capsule, can we just go ahead and treat it as a routine case and do a hydrodissection and go on with the surgery?
That is what we have described. I didn't go through the entire my presentation. If you have a type 1, type 2 of a posterior polar cataract as per the OCT description, there where we can delineate the entire posterior capsule clearly, there I do a routine surgery. I do hydrodissection, delineation, complete surgery in a few minutes. Where I can't delineate the posterior capsule, that means your either disc is very thick, or the nucleus is harder, or the size is bigger. There I am careful. I only do delineation, complete surgery slowly, and then go in. As Dr. Bharti also said, most cases may be like a posterior capsular type. So they have type 1, where you can see the capsule very clearly through anterior OCT. You don't have to worry there. You can complete a surgery like a routine case, become faster and safer.